Achilles avulsion. It's not very common injury, but it can present a lot of challenges to the treatment. So this first patient is a 70-year-old female, had a history of domestic fall and sustained calcaneal avulsion fracture. This was treated by my colleague, and you can see the immediate post-op X-ray here on the left-hand side. This is fixed with two 6.5 mm CC screws, and the X-ray in the middle is 6 weeks down the line. Patient was still non-weight bearing at that point, but X-ray on the picture on the extreme right reveals that this has resulted into wound breakdown. Just question to everybody: what are the ways people have fixed these fractures with successfully rather? Chetan?
Even I would fix with screws, obviously not coming out of the calcaneum.
Yeah.
Quite a few times that fragment causes impalement of the skin. So there has been a couple of times when I had to use an external fixator in plantar flexion for 3 weeks till there were some signs of healing. Or an anterior slab in plantar flexion.
But now you are presented this like in this condition, 6 weeks down the line. Panel, anybody wants to take further? What would you do at this point? You are now 6 weeks. You have got open wound, metalwork failed.
First thing is to debride the wound properly, clear the infection, and we'll also consider taking out the implant at the same time.
As Sir said, it's important to get rid of the infection, remove the screws, remove the tenting fragment, and don't worry about the tendo-Achilles. It can be managed anytime later. Just control the wound.
So whenever I actually get this injury, primarily referred to me, I involve plastic surgeon. I'm fortunate that I work in an institute where I can get plastic surgeons easily. So initially what I did without plastic surgeon was taken out all the pieces of bone. You can see the extreme right hand side picture of the X-ray where there is no fracture left anymore. All bone is out. The tendon has been sutured only with Vicryl directly into the calcaneum bone. This is the defect which has been left after the debridement. VAC has been applied. 2 VAC changes were done for this patient. This is again left hand side picture shows this is a VAC is out now, but we could not get the ankle to neutral. So, and you can see the underneath tendon is exposed. If you leave in this condition, patient is likely to get TA tightness and further procedures necessary. So we involve our plastic surgeon who did the rotation flap and the skin grafting up there. This is a picture 3 months left hand side, 6 months fully healed and mobile patient with single head break possible. Good result after flap surgery. Any questions?
So regarding the primary management of this question, of this injury, as I said in the morning, I burnt my fingers, and just these 2 screws most of the times are not enough. You have to fix it as we fix a greater tuberosity of humerus. With additional sutures in the tendo-Achilles, do a tunnel in the inferior surface of the calcaneum and tie it there over a suture button or endo button. You need an hybrid fixation along with the screws.
Okay, so
that was my question. What would you have done on day 1 if you had gotten this injury? Which was answered.
So on day 1, what would you do if that was the...
Actually, this is actually one of the true emergencies. If you get to see some picture or already necro scheme, this has to be reduced. Either you put K-wires, or as Chetan was saying, you can put X-fix, whatever modes you have, or even a percutaneous screw to get that tuberosity back on, and then wait until the wound really settles and then plan for final fixation. The reason I did not answer your question fully because the next case will answer that question.
Okay.
So this is a referral directly to me as a first surgeon. Another 70-year-old domestic fall. You can see left hand side calcaneal avulsion. This is the skin condition, not bad, but a lot of bruising was there. So I was going through the literature. There is a longest case series to deal with. These are 5 or 6 patients, and they have described a Krakow type suture technique and augmentation of that suture using the couple of screws. So I thought, let's do that. So this is the intra imaging. You can see the Krakow suture has been taken and this suture is going around that screw. So this screw is actually not, it is away, is in the remaining body of calcaneum, and this suture is pulling the whole tendon and going round. Knot has been tied, screw has been tied, and these two K-bars you can see here, the two CC screws were inserted. This is an immediate intraoperative X-ray, post-operative X-ray. 3 weeks down the line, when the sutures are removed, this is how it was looking. So not wound complications, pretty good wound. So I thought I will do my usual mobilization plan, which is a boot and wedges in equinus, and patient will fully wet. Week later, this happens. Wound is still very good, no problems with the wound, but look at the X-ray. Now question to panelists, what will you do at this stage? Now my fixation has failed clearly here. Any takers?
I would still go back again, remove those screws, fix with longer screws going into the anterior process, and neutralize with an X-fix, like I said. Because this is clearly the avulsion as a result of your tension on the tendo-achilles. So you neutralize that tension by keeping the ankle in as much plantar flexion till there is some healing.
In this scenario, I think again we need to remove it, and if the fragment is not coming up, remove the fragment, fix the tendo-achilles with suture anchors, augment it with the FHL. That is, I think, should work.
Yeah, exactly. This is what I ended up doing. Same thing again. I took out all the fragments. Nothing left there. You can see here the tendon has been lifted. But this time I used suture anchors to primary repair. No FHL tendon transfer was done. You can see this slight area of skin problem is there. So obviously plastic surgeon was with me as well for this case. But his involvement was not needed. We whacked this one. Immediately after surgery, on a closed wound, whack was applied, suture anchors in place. You can see the whack in place as well there. And this is the picture week down. So only one whack change was given. This was the picture after the first whack change, and this patient is still under treatment. I am hoping that she will probably not have any more wound problems and the tendon will heal eventually. So take-home message from this are there a very challenging injury to treat. Patient may present straight away with the skin necrosis. Fixation failure is likely. Wound complications are common, and counsel the patient for multiple surgery, especially involvement of plastic surgery. Because they say, I come for a very small fracture and you have given me such a big scar.
Okay.